Today we've got a great episode lined up with Dr. Mark Little. Now might be a good time to talk about Genesis 2. You want to talk about that a little bit, since we're just talking about pivotal studies? Okay.
Yeah, so Genesis 2 is a large randomized sham-controlled trial. So it's 110 patients, one-to-one randomization. So half the group are randomized to GAE, and we're using 100 micron embazines. Half the group are randomized to a sham procedure, and it is a true sham procedure. So we go into the common femoral artery, we get our catheters down into the genicular arteries, we do runs, we see the hyperemia, and instead of injecting particles, we inject saline, so 0.9% normal saline into the vessels. So it is a true sham procedure. I'm obviously unblinded for safety purposes, but the patient is blinded, as are the clinical team, the research nursing team involved in follow-up. The patients are blinded to 6 months, and at 6 months we unblind. And during that time, we are collecting lots and lots of data, the primary outcome being KOOS, so the knee injury and osteoarthritis symptom score, which is a validated questionnaire throughout a lot of the orthopedic literature on knees, and also within some of the IR literature on GAE. And so what we do at 6 months is we then unblind and say to the patient, look, how's your knee? How are you getting on? And they say, oh, it's terrible. And hopefully I say, well, that's because you had the sham. Would you like the real one? So we do a crossover at that point. So if you've been in the sham, you can then have the GAE. And that's kind of that's the buy-in, isn't it, for this trial? Because initially I designed it that it would be 12-month follow-up, and it would be purely one-to-one, and there would be no crossover. But I think as the data was emerging of it, the cohort studies showing more and more promise of, 65% benefit, it became tricky, not just from an ethical perspective, but also from a recruitment perspective of not having that sort of carrot saying, well, if you get into the trial, the buy-in is you do 6 months, and then if you haven't had the true procedure, you can have it. So that has helped, I think, with recruitment. And then at 6 months, that's our primary endpoint. So we'll be comparing the data from treatment and placebo, and then the sham will cross over, and then we'll follow both groups to 2 years. So that's the study design. And as I say, we're going to collect a lot of data, not just the KOOS, but we're going to do visual analog scale. We're going to look at EQ5D, which is a quality of life questionnaire. We're looking at cost effectiveness analysis, so looking at the economics of this. So it's fully loaded, as well as analgesia and concomitant treatments, as well as safety. So obviously very important to look at the safety as we go along. So yeah, we started that, a year and a half ago now. I think we are halfway through. So it's a complicated trial. There's lots of elements to it. They all get contrast enhanced MRI of the knee beforehand, then at 6 months and at 1 year, to enable us to really assess the impact on synovitis, but also look for complications within the knee joint, like we did for Genesis 1. And then, as I was sort of talking about in my preamble, I'm quite interested about the neuropsychology of things. So as with Genesis 1, we've added into Genesis 2 some experiments to look at that. So they undergo functional magnetic resonance imaging of the brain to look at neural activation and try and correlate areas that are associated with chronic pain with outcome. And they also undergo an assessment of their pain threshold. So we apply a heat stimulus to their arm using a calibrated thermistor and ramp up the temperature and see how they respond. And then we also do some questionnaires, so looking at how their neuropsychology, so looking at depression, catastrophizing, sleep, raft of things, which is very much led by the psychologists within my research group. We're trying to look at lots of different things. I think, from my perspective, it's too simplistic just to say we put some particles in and everything gets better. We need to really think about this in the round and ascertain look at lots of data to try and really understand this procedure and the outcomes of it.
And you mentioned embolics. I did want to ask you, what embolic materials are you using, and what all have you tried, and how has that your technique evolved since you started doing this?
Yeah, so Genesis 1, we used 100 to 300 micron embospheres from Merit. Initially, we started with sort of increasing the sort of double diluting, but actually now we just make that up to 22 mils within the vial. So we get rid of the air that it comes in and just dilute down with 100% contrast. And then what we would do is we would decant sort of start maybe about 0.4 mils, load the catheter. It's just slightly more than the dead space of the catheter we use. So we're using a 2 French Pursue microcatheter. And then we would flush that very gently with saline. And that's how we're embolizing. So we're doing it in aliquots of around 0.3, 0.4 mils so that we go nice and slowly because these are small areas. We want to prune the abnormality, so get rid of the hyperemia but maintain the normal inflow. So that's how we are utilizing and handling the embolic. For Genesis 2, we're using another permanent, but we're using embazines, so 100 micron embazines from Varian. With that, we are making the product up with 10 mils of contrast and 5 mils of saline to get a nice suspension. And again, the delivery is identical. So we will load the catheter dead space, 0.3 to 0.4 mils, and then slowly clear with saline. From there, we will then load again if required and keep going until we've got good pruning of the abnormality, but maintenance of the normal genicular arterial inflow. Obviously, there's a bit of a geographical divide. You probably heard me speak about this at congresses, in the Far East. Yuja Kunu and the groups from South Korea are using temporary embolic agents, so imipenem and cilastatin, which is actually not an embolic agent at all. It's an antibiotic. But when it comes into contact with blood, it produces a temporary embolic agent. So it produces sort of these crystals in a range of sort of 70 microns, and they disappear in a couple of hours. And that's been used in a lot of the MSK territories, not particularly outside of the knee, where you need a resorbable embolic. The problems with imipenem is that it's not a licensed device, and it's an antibiotic. So again, potential issues with regards to antibiotic resistance, etc. So we need dedicated resorbable particles for MSK embolotherapy. There are several that are being looked at. You've got NextSphere by Next Medical, which is recently just got licensed to be distributed in the UK. So that's exciting. So we will have access to a resorbable particle. I'm actually working with a company in Ireland called CranMed. Been doing a lot of research with them on a novel resorbable embolic agent called Securabid, and we've just finished our first in-man trial of that. So that's pretty exciting as well. So I think in time we will get access to dedicated resorbable embolic agents, and that will open out the MSK space, certainly beyond the knee. As I say, at the moment we are limited to licensed permanent spheres within the context of our research studies.
Yeah. And then I saw Mark present something on lapio joints, this lapio joint trial. I mean, can you speak on that I don't know if you have tried that technique? I know Oz has tried it. Yeah,
no, we haven't tried it as yet. Again, looks interesting. So he creates an emulsion using Lipiodol to put in the 3-way tap, and you create sort of an emulsion, which is then used to inject into the selected genicular arteries and embolize it. Obviously, we've got the early data from Mark Sapoval's work. It's good. I think, all data is good data at this point. We need to keep exploring the space. I don't think I'd advocate liquids at the moment. I think that would be too proximal and might lead to issues. I think you do need to get out there in terms of the distal genicular arteries. So I think for me, I'm still a believer in the particulate embolotherapy aspect or embolization of things. But, I think we just need to keep going with the data.
I wanted to talk a little bit about, I know you spoke about this at Guest, MSK, was a little bit about like challenges, especially challenging anatomy, especially given the territory, PAD, right? I mean, I know, a lot of these patients are, middle-aged, but middle-aged, we do see, especially in diabetics and people with significant atherosclerotic disease, they got PAD down there. Can you speak a little bit about that? Just in, not just PAD, how you overcome PAD, but also any other anatomic challenges that you've come across?
Yeah, so we've done a lot of work on the anatomy with regards to GAE. Published a paper looking at a study we did looking at cadaveric dissection and the angiographic data. And with regards to the anatomy, it can be complicated, and there's certainly a learning curve when you start. The difficulty with the genicular arteries is there are lots of anastomoses between them. And sometimes that can be great because you can get into the descending genicular artery, get distal, and you can see the superior medial, and you think, oh, okay, great, I'm in this, that's the backdoor territory, so I won't need to then get into that one as well. So you can embolize from a single point. Sometimes, though, you get anastomosis to areas that are slightly less favorable. So it might be a vessel that goes to, say, the medial sural arteries, which are the vessels that supply the tibial nerve, or you'll get an aberrant supply that goes directly into the popliteal artery. So you've got risk of non-target embolization down the leg. So you do need to be familiar with the anatomy. We use cone beam CT on all of our cases as a checkpoint. We did it, very much from the beginning when we started as a safety measure. The way we do that is we actually get into the genicular artery and then we do a spin, 0.3 mils per second, 6-second delay, 6 mils of contrast. And that enables us to actually see if we're going to inject particles next, what's going to happen. So to make sure that we haven't got a big anastomosis that's going to embolize bone, muscle or skin or go down the leg. So that, I think, as a sort of tip, if you've got access to cone beam, that's useful. I know that not all IRs do, particularly those in the OBL setting in the US, which is slightly very different to our setup in the UK. But I think, starting out, that's useful. With regards to peripheral vascular disease, I think it's pretty binary, really. You shouldn't be doing GAE in someone with peripheral arterial disease. And we don't get CTAs up front. What we do is when we see them in clinic, we ask them questions. So say, has anyone ever told you that you've got problems with the arteries of your lower limb? Do you get any pain in the calf when you walk? So we try and screen it. Do you smoke? Have you ever smoked? If they have, significant smoking history, what I'll do is I'll just take them next door and I'll just whiz the ultrasound down and say, okay, what's going on here? If they got any calcification in the common femoral artery, what does the popliteal look like? If there's any disease, I'll say, look, this isn't for you. Because I think, as we know from the peripheral vascular disease literature, the genicular arteries are absolutely crucial to providing those bypasses to occlusions. You see it all the time. Popliteal occlusion, the genicular arteries are huge and they provide this wonderful network to supply the lower limb and prevent you losing your leg. So I would strongly advise you do not perform GAE on anyone with significant peripheral vascular disease. I think that is a recipe potentially for disaster, particularly where we are with the technology and the technique. And things may change, like all things evolve. But at the moment, I would hate for someone to have a significant complication that puts us on the back foot.
Absolutely. I mean, would you say it's a absolute contraindication?
Yeah.
I guess it depends on the level of...
Yeah. I think, okay, it depends on, what you're defining. But I think, if a little bit of calcification in the common femoral artery, I mean, that's quite common in someone over 70. But if you've got any stenosis that's greater than 50%, within the SFA or popliteal, I would be very, very nervous about intervening on those patients. I really would not, and I've spoken to Sid about this, and I think we're both on the same page. I think it is really an absolute contraindication because these patients down the line, their disease may progress. And if you've taken out the geniculars, even with pruning, you're potentially limiting their ability to provide a bypass, for, as God intended.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTableMSK on Instagram, Twitter, or LinkedIn. BackTable is produced and hosted by myself, Jacob Fleming, and co-hosts
Michael Barraza
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Junior Kennebrew.
Thanks again, and see you next time.